Hello, I'm Jeff Seaman, and I'm a board member of the Scleroderma Research Foundation. I became passionate about scleroderma research 5 years ago when my daughter was diagnosed with systemic scleroderma. Before we start this next session, a quick note. You can participate in the poll available now to share a little bit about yourself and learn more about everyone else participating in the session today. Now, I'm excited to introduce our next session, Stem Cell Transplant in Juvenile Scleroderma, and our speaker, Dr. Kathryn Torok. Dr. Kathryn Torok is the director of the Pediatric Scleroderma Clinic at UPMC Children's Hospital of Pittsburgh. She juggles seeing patients in the clinic, conducting her own research to help develop more effective therapies for localized and systemic scleroderma in children, and mentoring in the next generation of pediatric rheumatologists at the University of Pittsburgh School of Medicine. Over to you, Dr. Torok.
Hi, everybody. I'm Kathryn Torok. I'm one of the physicians at the University of Pittsburgh Medical Center, the Children's Hospital of Pittsburgh. We have a specialized juvenile systemic scleroderma program, and I'm happy to talk to you and the Scleroderma Research Foundation about it tonight. We're just going to go over a little bit about what a stem cell transplant is and what patients with juvenile scleroderma that would be applicable to get that therapy. So this is just an intro picture of my nurse who just retired after 44 years, Vicky, and Sophie Ann, one of my patients who is happy to be on our cover. So just another nice little clinic picture. Just a refresher, this is what juvenile systemic sclerosis looks like, or juvenile scleroderma. Some of the skin changes of the face, giving you tight lip, sometimes retracting around the face, etc. Tightness all throughout the body as well, with that chest that gets really tight, almost looks like a body of armor. And then other changes occurring in the fingers with Raynaud's, digital ulcers. Sometimes if it's going on for a while and getting deep into the tendons, you get some of the claw hand and other changes. I wanted to show a little bit of calcinosis that can happen in a subset of patients. Interstitial lung disease, so this is a CT scan, and you can see there's extra inflammatory infiltrate and some fibrosis that should not be there. The lungs should be completely black. And then growth delay. So sometimes the initial onset of systemic scleroderma in kids is that they're kind of starting to fall off the growth chart for the pediatricians, kind of the weight, the height, and sometimes the body mass index. So that's just a snapshot of what we're talking about is scleroderma. The other thing that we're talking about is a stem cell transplant. So what the heck is a stem cell transplant? So hemopoietic just means it's made from the bone marrow, is where kind of the blood cells that we talk about are from. But moving forward, I'm just going to call it stem cell transplant. And there's two main types. So if you know anyone with maybe a cancer like leukemia or something, you may have heard of a stem cell transplant. Most of the time, those are what we call allogenic, meaning non-self. It's not from the patient, it's from a donor that's matched. They match the immune cells and kind of give that person a new immune system. So in scleroderma, we don't do that. We do the autologous, which means self stem cell transplant. So basically taking the cells out of the patient and kind of then siphoning them through a machine to get kind of the baby or junior cells that aren't mature enough yet, and kind of freezing those baby cells down that haven't made a decision to do bad things yet. And then later, after some chemotherapy and sometimes radiation, then infusing those cells back into like a clean slate and letting those cells bloom or blossom in a new environment. So this we consider like an immune reset. So these immune cells then can grow and be healthy, and you want them to have make all different kinds of cells. So sometimes in autoimmune disease, they're just kind of stuck, the immune cells making like very similar type of cells. So kind of getting those more juvenile cells in a new environment lets this cell, it's called diversity. It's like different kinds of like T cells or B cells, for example. So that's what that's what has been done in adult scleroderma for a little bit of time, probably about 20 years now, is this autologous or stem cell transplant, or ASCT. This is just a general diagram. We'll go into this in a little bit, but there's steps along the way as far as kind of getting the stem cells out of the system, collecting them, then like hitting the body pretty hard to get the remaining immune cells out or knocked down with the chemotherapy, et cetera, and then infusing those new baby cells, and those baby cells then mature in a healthy environment and make new neutrophils or white blood cells and lymphocytes as well. So that's the general kind of overall idea behind it. And this is just showing that the overall biological part is to basically make the diverse, healthy T cells and B cells. So moving forward, the body's not attacking itself in the classic autoimmune disease, and that's what systemic scleroderma is. This is just another diagram showing the same thing, the general kind of steps of a stem cell transplant. And this is a stem cell transplant in general, whether it's for scleroderma or not. Those were the main steps that I was kind of going through. So basically, you're trying to really, after you kind of remove or take those stem cells out and freeze them down, you really are trying to give this intense immunosuppression. And the harder the immunosuppression during this time, the kind of better long-term outcome the patient has, because you're really trying to just, for better words, like annihilate the immune system before you put those fresh baby cells back in there to kind of grow. So this was a better alternative back 20 years ago or so when the adult scleroderma folks started doing this, compared to the IV cyclophosphamide or IV Cytoxan. That is a chemo agent that we use in scleroderma and lupus, but it seemed like this might be a better option. They started just noticing clinically that the scleroderma patients with the stem cell therapy were doing better than the standard of care. And at that time, it was this high dose Cytoxan, and that has its own side effects. So the three kind of landmark trials are called ASSIST, ASTIS, and SCOT. The two that had the larger number were the ASTIS in Europe and the SCOT trial in US. So if you hear one of the doctors say SCOT trial, that's what they're talking about. So basically, it was cyclophosphamide versus stem cell transplant in adult systemic scleroderma patients. And in both of those studies, I'm not going to go over the data, but it's just to show that the survival was significantly better, both clinically and by the numbers, like statistical numbers, in the patients that had the stem cell transplant compared to the Cytoxan. So if you just think of like green, shades of green are good. So there was more good happening in the transplant group versus the Cytoxan group. There was more red, some side effects, morbidities, and even more death in the Cytoxan group. Again, these are adult scleroderma patients. So the patients with the stem cell transplant in adults did well years outside of the transplant. So there was some initial risk from the stem cell transplant itself in that first year or two. But then after you got beyond that, the transplant patients were living way higher than expected with the Cytoxan in both studies. So that's why it was kind of a popular thing with the adult rheumatologists. And in pediatrics, there's really only a few case reports. If you add these up, it's just in the low teens. But so there were stem cell transplants, but it's just kind of a few patients at a time in different centers. And again, kind of a little bit speckled around like the 1990s and the early 2000s. And on average, they were around 12 years old. And in general, they all had different outcomes, so it's hard to compare apples to apples. But in general, most of the patients did do clinically better. Their skin score was getting better, their height velocity, remember that growth chart, so they're getting back on the growth chart. They were in remission. Most didn't flare, but sometimes they did, but most did better, the skin improving, the muscle improving, etc. So that's the big, like, why do the stem cell transplant those were the landmark studies that said, hey, this is looking like a good thing in adult scleroderma patients. It looks like it's better for the survival of these patients that have bad interstitial lung disease and or skin disease. And over time, they showed that this was a better safety. In the very beginning of stem cell transplant, there was a little bit higher mortality rate, and then they got it down to like 5 to 10%, which for adults, that's good. That's like in a good margin. And then on the pediatric side, the pediatric rheumatologists were getting together to make these guidelines. This is a European group called with the publications called SHARE, Single Hub and Access Point for Pediatric Rheumatology in Europe. And a group of experts got together and they made 100% consensus that they felt, given the data from the adults, that autologous stem cell transplant would be an option to treat patients with juvenile systemic scleroderma with progressive disease refractory to immunosuppressive therapy. And when I say immunosuppressive therapy, that means CellCept, methotrexate, rituximab, Actemra, the various medicines that we have available. We were developing the center, and I would say this is probably around 2018, 19 is when things started to come together. First for the adult side, and then the pediatric side kind of joined. And now we have like a cohort 1 and cohort 2 for our stem cell transplant program. And that's been a little more established since like 2021, I would say. So at children, the cohort 1, the pediatric part of it, we enroll patients 8 years or older up to 24 years old in our arm of it. If you're older than 24, you can definitely get it. It's just you'd be on the adult arm of the study. And we see patients as a team. So there's myself in rheumatology, the cardiology, pulmonology, gastroenterology, especially for the motility issue. If anyone has a child with scleroderma knows that that's an issue. A lot of the GI problems, our specialized bone marrow transplant and cellular therapy physicians, psychology, physical therapy, etc. So we kind of all work as a team together, and we evaluate the patient together and say, hey, this patient is a good stem cell transplant candidate, and obviously talk to the family, see where they're at, if this would be of interest of them or not. And then we'll get into some of the data, but thus far we have 7 patients that we've done this stem cell transplant. We've consented 2 more, and all of them have had overall really good, favorable clinical benefits. Many have said it's been life-changing. I'll give you some examples in a few slides. So it's really made a difference, going from being kind of stuck in a hospital bed for one patient I'm thinking of, and like 2 adult people helping to move her to basically her on her own, getting up out of the chair and kind of walking around, which had not happened in, a year and a half. So definitely some amazing things that can happen. But I was talking about the regimen, there's chemotherapy involved. It's definitely an engagement and an involvement and a commitment. But, for those that need it, it is a reasonable therapy for sure. We are not going to go over the details here. This is just a cartoon that my student helped make just to maybe put this a little bit easier as far as like getting a general roadmap. So this is typically a couple months. So maybe like a month and a half before the stem cell transplant that things need to happen to prep the body. Then a couple days of that intense chemotherapy, radiation, then the immune system is like wiped clean, and then you get the stem cells, and then you let them grow, and you're hospitalized for about a month or so. Then you get discharged to our Ronald McDonald, which is connected to the hospital. So you're discharged, but you're kind of like still Pittsburgh, but you're going back and forth to the bone marrow transplant outpatient, maybe like 2-3 days a week for a few months until your immune system really kind of develops and you're in a safer place to be able to go kind of do more social things, etc. So there's some pre-prepping time, the radiation chemo, and then infusing the stem cells, and then recovery time. I think some people want to know, well, who the heck, got a stem cell? Like, what do these patients look like? So this is patient 1 and 2, their lungs. So patient 1 and 2 had pretty severe interstitial lung disease. We do different things to figure that out. So one is a chest CT, another is a pulmonary function test. If you guys have ever had a child that has done this or done it yourself, it's pretty hard. You're breathing through a tube and trying to look at the lung volumes. And then also the DLCO, or exchange of gas in the lung. So if you have these fibrotic areas, there's just no space to exchange that gas, so your DLCO is low. And if you have a lot of inflammation or loss of like the functional units within the lung, then your FVC, or your functional vital capacity, is also low. So these patients had on the lower side of a normal DLCO is 80 or higher. So these patients had more of like a 28 to 35% DLCO. So very, very affected. And then the third patient, actually, she started having a low DLCO, but it was actually due to muscle weakness. So the diaphragm and the intercostal muscles, the muscles along the ribs that help you breathe. If you have overlap scleroderma with myositis or muscle inflammation, that starts getting weaker and you're not taking those deep breaths. And then eventually you're not exchanging the oxygen as well. So you, in the end, might need like positive pressure ventilation. So to avoid that, we want to do the stem cell transplant to get this particular patient to get their skin and muscles better so that they could kind of breathe better. So even though they didn't have that disease like in their lungs intrinsically, they had the muscle disease. And that's something that I've been trying to teach other folks that may not be as familiar, you know, in medicine regarding scleroderma and the effects of muscles that it can have. So that's just an idea of some of the patients that we felt were good candidates and did have the stem cell transplant. Now, this is a busy slide and I really apologize, but the take home is these are the 7 patients that had the stem cell. Patient 8 was consented, so she did not get it yet. But just to give you an idea of the age range, so on average, their age of onset is 12. The time of the stem cell transplant is around 17. So several of them had been on different therapies before they kind of got here. I think moving forward after these initial 10 patients, the goal is to get the stem cell transplant earlier, not wait and burn through too many meds or too many times because you don't want damage to accumulate over time. And the patients were relative, you know, mostly female. That's what we see in adult scleroderma. We see that to some degree in pediatric scleroderma as well. We had around 40% Hispanic, so that's actually a fair representation. I don't have it on here, but we have at least around 35% African American as well. So we do have Caucasian African American representation as well here. And the patients were a little bit of a mix. So you'll hear the adult rheumatologist talk about like diffuse cutaneous, that means scleroderma affecting everywhere in your body on your skin. Limited, that's kind of like the thickening of the skin to the elbow or the knee. And then overlap where you have scleroderma features and you meet scleroderma criteria, but then you also have dermatomyositis or other like lupus overlap features as well. So those are kind of the patients. They had the different forms and their average skin score was around 26, which is high for a kid. It's even high on the adult spectrum. Usually 20 or higher, you're like, okay, that's pretty significant thickness because it's a global capture. But there are some patients that had a low skin score. Why some of these patients are highlighted is because they actually wouldn't have made the cutoff for those 2 major trials I showed you, SCOT and ASTIS, because they either had disease for too long, they weren't the right subtype of scleroderma they were looking for, or they had a lower skin score, or a poorer lung function that was able to go to those adult trials. They would be excluded. Their lung function was too bad. They wouldn't too risky. They wouldn't have taken them. So obviously we've made exceptions for the pediatrics because we feel like that they have more of a rebound. They have a little bit more gain of function down the road as a possibility, a little more reserve. So that was kind of a leap of faith on our end, but it did work out quite well. All these patients did well. So all of them had different various forms of the disease as far as Raynaud's, joint contractures, muscle disease, GI disease. And you can see on average for all patients were on average about 4 different medications before they got to the stem cell transplant. And they were on the typical ones that you might see in the rheumatology office. So how did the patients do? Overall, they did great. In as far as like the general protocol, I'm going to bypass, that's just the general protocol. But one thing that the BMT folks really like hang their hat on is, okay, what's their engraftment? Engraftment means like when those cells, after you infuse the baby cells, the stem cell transplant of the patient, when do they start to kind of grow in this new environment that doesn't have any of the bad cells circulating because you did chemotherapy and radiation? So on average, the neutrophils or the PMNs, those guys will come back around day 11. And then the platelets, which help clot your blood and everything, they come around day 19. So that's like pretty on par. Sometimes there's a delay. There's one patient that unfortunately just had adenovirus. That's like a typical run-of-the-mill virus that's around, like gives you cough, cold, runny nose. That did delay their engraftment, but then they did engraft. So that's a successful stem cell transplant. It engrafted overall, like when it was supposed to. There were no major safety concerns. There's this one medicine called ATG that at first was made with horse serum, but they found that the patients had too many reactions. So they switched that to a rabbit serum version, and the patients did fine. There were no serious infections, no ICU visits, no serious organ dysfunction. So no new scleroderma renal crisis, no cardiac issues, nothing else new popped up. So this is one of my patients, and this is actually her summary. It's going to be in her newsletter. She gave me permission to share. Her name is Serenity. She also gave me permission to share. She's in college now, and she was hospitalized for about 1.5 to 2 years before she got the stem cell transplant. And her and her mom, made a team effort, and they're like, chance, we're going to take this chance. It may not cure me, but it's a chance to live a better quality of life. And scleroderma doesn't define me, so I'm going to give it a chance. So this is her sitting on the floor in physical therapy with me, and she had not been able to get down because of the joint contractures, the skin, the limitation. She could not physically even attempt to sit down for 1.5 years. So this is her almost a year after stem cell, and she was just joyous that she could get down on the floor. So that was just an example of a real life patient with their permission. And I'm just going to wrap up with a couple things. Is basically the overall the stem cell transplant was well tolerated. There were no, thank goodness, no mortalities or anything in the pediatric arm. This is just one of the outcomes when people talk about a stem cell transplant trial. And then a lot of the secondary aims, like the treatment effects, were positive. Let's take a look. These patients, some of them call it their rebirth day. One of my patients, and now he's married. My first patient, again, Caleb, he gave permission to share. He just got married in April. He's now about 22. So 4 years out on no immunosuppression. He had the stem cell transplant, and then he's just on kind of GI meds, normal maintenance meds, but that's it. And then my other patients, said, hey, I had my best quality of life after it. I could go on a bicycle without gasping for air. This is one of my patients at the Kids Get Scleroderma 2 conference. So they all felt like various aspects of their disease and their global quality of life improved, and across different organ systems. So this is an abstract that we presented at the ACR. And I will go into the next slides that break this down, but basically skin domains, global well-being, vascular, gastroenterology, pulmonary, manual function, all of those got better after the stem cell transplant in these original 5 patients that we had longitudinal data in. So these are a little bit easier to look at. So for example, the skin thickness, which defines systemic scleroderma in a lot of the clinical trials, you saw the average was about 26, right? Well, it went down to a score of about 2 for most patients, which is remarkable. You can see that baseline blue at before the stem cell, and the orange is 1 year later, and the gray is 2 years later. The only mild bump in the road is one patient that had the overlap with the muscle disease, the myositis. She did have a flare of the myositis about 12 months out. So you might see that patient three kind of have some variation, but the rest of the patients have kind of a smooth improvement. Finger to palm, so they can move their hands, grasp things better. So that goes from 3 to 0. They can go down all the way. Oral aperture, able to open their mouth more because the skin thickness was less. And the CMAS is a muscle indicator, how strong you are, and that improved in several patients as well. And then the lung functions, overall stabilized. That's what you want to see in the stem cell transplant, because the natural history for lung disease and scleroderma is to slowly get worse in function. So overall, we saw the patients stabilize. A few got a smidge better. And then the DLCO is actually 2 years out. We did see 2 or 3, actually 4 patients get significantly better from their baseline. So a DLCO about, somewhere around 36 to 56. That's a real change. So there's definitely some patients that got better there. And their 6-minute walk distance got better for all of them. That means how much you can walk in 6 minutes, and also that you're not desaturating on that oxygen probe that's either on your finger or your forehead. So they were able to kind of walk further distances and be more comfortable doing that. So that's a nice global measure. And then some other things that improved that we weren't 100% expecting, but their body mass index for most patients improved. It increased. It's good. You want to gain that healthy fat and weight. Their lower esophageal sphincter. So here, this little area that stops food from the stomach going up into the esophagus is usually pretty loose or low in scleroderma patients. We actually saw that pressure increased after stem cell transplant, which we were not expecting. So that was a pleasant surprise. And not all patients, I'm just showing you the first 3 patients. The last 2, it was kind of the same, but at least in some patients, it's improving. And the same thing with the acid exposure, it decreased after the stem cell transplant in I would say, the majority of patients. The patients overall, their scoring, when we asked to do their scores, they feel like that they significantly improved. And you can see that blue at baseline is high. That's more impact. The scleroderma impacts them more on a day-to-day basis. And orange is the 1 year. So you could see that impact went way down. Still obviously some impact, but way down. This patient felt like there was still a fair amount of impact, but less. So that's good. And then the check is their function. So that kind of improved to some degree. You want a low score. A low is like you can do everything. And then the GI patient reported scale also improved. It went from a little higher to a little lower. So you can see not all patients improved in every single measure, but I would say if you're looking at it, 4 out of 5 improved in most of the measures. So the take home is that, we did see this improvement noted at 6 months, and it was sustained at 12 and 24 months for the majority of patients. We talked about that one patient that did have a flare. She did have to go back on immunosuppressive medicine. So that was, a little bit of a bummer, but no new organ manifestation, nothing else happened. So just showing overall that this is safe and effective in these patients, and that long-term maintenance seems to be working well in these patients. So we might kind of start to expand the stem cell transplant to kind of, as I was mentioning, patients with earlier disease. Maybe they don't have to fail 4 things, maybe just 2 medicines, things like that, if they seem to have rapidly progressive skin disease or lung disease, etc. So this is my team, and it keeps expanding. I know I'm missing some folks, but I have a clinical team, a research team, a collaborative multi-center team. So thank you to everybody. And then obviously my patients, because without them getting involved in this study, we wouldn't know how it was working. So, and thank you to the patients for sharing their stories as well. Really appreciate that. So thank you. And we'll open it up for questions, I think.
Thank you, Dr. Torok. That was fascinating. My name is Jeff Seaman, and I'm on the board of directors for the Scleroderma Research Foundation. You've already covered a lot of ground, but I know there's some additional questions out there we wanted to throw your way. First of all, with so much interesting progress and the 7, almost 8 patients that you've covered, what are the next steps after you get to patient 10? And when you talk about expanding, what does that look like for you in the years ahead?
Yeah, thanks, Jeff, for meeting with me tonight. It was great that we get to chat a little bit. And yeah, I'm all about the next step. That'd be great. So our initial proposal for this is 10 patients, just to prove that we have safety. And we, thus far, with the patients that I presented, we've definitely accomplished that. And what we call is efficacy or outcomes improving, like the skin score improving, range of motion of muscles improving. We are accomplishing that as well, but that's just kind of like the candle on the cake. That's kind of the bonus we're excited about. So once we get these 10 patients through, and like I said, we considered 2 more recently, and show continued safety, I would say probably up to 6 months the minimum, but a year, then we can start applying for, we'll start working on that in the background, but applying for funding for grants that have more of a clinical trial, where you kind of enroll a patient into the stem cell transplant earlier in the disease. And, I have to think about it if we're going to compare to certain medications that are out there or not already, or just kind of an open enrollment like our current study is, but just kind of change the criteria a little bit, kind of loosen them up. That's kind of my goal, is to loosen up the criteria, that they don't have to be as sick. Obviously, you don't want a very mild patient getting a stem cell transplant if that's not what's necessary. But if you can kind of get predictors, see the writing on the wall, the skin score is escalating pretty quickly. The interstitial lung disease is also escalating, things of that nature. So we're working on predictive markers, clinical and biomarkers right now, so that we can kind of more confidently enroll those patients in an earlier study of that nature. So that's the goal. So kind of get these kids before, as you saw, the average disease duration was about 5 to 6 years before they got the stem cell transplant. So we're trying to get them maybe a year or two into diagnosis and treatment.
That would be fantastic if we could catch it earlier and start on this very promising research. That'd be really neat. Mm-hmm. You touched on, maybe, as a parent, and you're the doctor, right? You figure out how to get the stem cells out and all that stuff. That's your world, and I'm fascinated to watch it. But afterwards, what does it look like for a patient? You mentioned a handful of months at Ronald McDonald House. Can you expand on that? Is it intense in those first 2 to 3 months in Ronald McDonald House? And then what does it look like in maybe months 4 or 6? When can you kind of get back to more normalcy? Maybe expand on that timeline a little bit more.
Yeah, Jeff, that's an excellent question, because the patients, we're a center, so a lot of patients fly from various places, like California, Tennessee, et cetera, and they would have to kind of uproot their family for a handful of months to have at least one caregiver. They can switch caregivers, but as long as there's some consistency there with the patient as well. So obviously that's a big commitment from school, from work. Right. A lot of the parents are like, okay, I can do this because I can do online, right? And make sure that they transition to an online.
So school is definitely an option while they're going through post-recovery.
Yeah, so that's a great. So remember, we're doing this within the auspice of bone marrow transplant. So they do this type of thing for kids with leukemia and things like that for years and years. So they have a setup system of social work teachers. They have a teacher that will see the patient in the very beginning and say, hey, even if you're not on PA Cyber, but you want to join this cyber program that we have. So they have different things to kind of help keep, if the patient wants to do it. A lot of the patients, I would say, during that intense conditioning is what that's called, when you get the chemo and the radiation, they're not really up for doing the online school, but that's usually just a week or two. Then most of my patients want to do the online school if it's, not during the summer. And the parents are kind of like in the room working on their computers as well. But as far as ballpark commitment, it's usually about a 4 to 6 month, because you have like a month of pre-stuff that I was showing you, mobilization, things like that. A month where you're physically like in the isolation part of the hospital, where, just a parent or two can kind of come in and out. But that's when the immune system is knocked out and they just got their stem cells and they're trying to make them grow. That's when you're just most susceptible to the viruses and other things that are floating around. But then after that month, you do get discharged to that Ronald McDonald, and that's around 3 months-ish. And you're seeing all outpatient the rest of the time, but you're seeing the bone marrow transplant folks a couple times a week. You'll see me or the cardiologist, every once a week or something like that. So there's definitely, like, Pittsburgh will be their home for a good 4 to 6 month span, depending on just how long some things take. But that's kind of the general things that parents should kind of keep in mind when they're engaging on this process.
Very good. That's very interesting. As the patients move along the spectrum on post-recovery, are there any special dietary concerns? Right, we know scleroderma affects the GI system a lot, but after you get your new immune system, the immune reset, any lifestyle or dietary constrictions or restrictions that we have to worry about?
Yeah, so I would say like a year down the road after the stem cell transplant, no, like you can eat whatever you want. It doesn't need
ice cream here, right? Everybody loves ice cream.
Yep, you can get ice cream. But it's just that intermediate couple months after the bone marrow transplant, I leave that up to the BMT team. They have their set protocol, again, because they do this for kids with other conditions as well. But there's certain things that they just don't want. It's more about the immune system's just a little naive while it's kind of figuring things out again. Kind of vegetables have to be washed a certain way. They just don't want like microbes that are hanging out on like vegetables, and no sushi, raw meat, stuff like that. But that's just a couple months. And then they kind of lift the restrictions once those cells I was mentioning, like the neutrophils and lymphocytes, once those start really populating. then they'll kind of lift those restrictions. But it's no lifelong restrictions. It's just those couple months.
And with the new immune system, I'm assuming vaccinations, all the childhood vaccinations that we all get, they would need to be reintroduced again post recovery. Yeah,
and that's something actually that I learned, because remember, I'm a rheumatologist, but I had to learn to be a little bit of a bone marrow transplant doctor as well. Is that the kids, it's a fresh slate, which is a good thing, right? It's kind of like they check the vaccine titers, but most won't retain any vaccine titers, so they do have to redo all the childhood vaccines. So a little bit of a bummer, but it's also a good sign that it worked. It did kind of like wipe out and give you a brand new, fresh immune system.
Yeah, well, this the whole stem cell transplant seems extremely promising. Thank you for working on it and getting 8 patients enrolled and sharing all the results with us today. So thank you very much for your time. Our time is up today. So I did want to just say thank you and sharing your insights on the stem cell transplant, specifically in the juvenile scleroderma. One last note, I'd like to invite everyone to take our post-event survey. The link will pop up on the screen at the very end of the comments. We value any feedback you have to share to make next year's patient forum an even more meaningful experience. Thank you.
Thank you.
And that was our last session. Hi, I'm Joanne Gold, Executive Director of the Scleroderma Research Foundation, and I want to thank you all so much for joining us. It's been truly inspiring to have so many of our friends and collaborators from the scleroderma community be a part of today's forum and to help us kick off Scleroderma Awareness Month. Before we close, I'd just like to give a special thanks to all of our presenters, SRF board members, and staff who've worked so hard behind the scenes to make this event happen. We're also deeply grateful to our industry sponsors at Johnson & Johnson, Merck, and Caverna, whose generous support and partnership make this educational forum possible. It's obvious that research is the key to finding a cure for this disease, which is why research has always been at the center of everything we do at the Scleroderma Research Foundation. But we can't do any of this without you. It takes a dedicated and courageous community to tackle such an ambitious goal. And by working together, we will one day end scleroderma. Thank you all and have a wonderful rest of your day.